Hi, my name is Brad McGregor, and I'm a GU medical oncologist at Dana-Farber Cancer Institute. I'm really excited to be talking with you today about our phase 2 trial looking at the role of cabozantinib combined with nivolumab and ipilimumab in those patients with divergent histology, also known as non-clear cell kidney cancer. So when we think about non-clear cell kidney cancer, we know those patients with divergent histology are heterogeneous disease with a worse prognosis than their clear cell counterparts. And we early on recognized that we needed novel therapies. And so we designed a trial where we combined Cabo at 40 milligrams with Nivo Ipi, akin to what was done with the Cosmic 313 trial. We showed objective response rate of 21% in 40 patients, but 77% experienced over grade 3 toxicities and half required steroids. So as we think about this as a whole, we recognize that this regimen was not going to be something that could be used in the clinic. So to mitigate toxicity and optimize the immunotherapy dosing, we looked to explore an alternative dosing of Cabo. And so now we report the first results of the multi-central single-arm phase 2 trial using 20 milligrams instead of 40. So again, schema, patient with metastatic RCC with divergent histology. We're starting Cabo 20 milligrams daily with Nivo Ipi at standard dosing. After 12 weeks, the patients were benefiting. They would go on to maintenance Nivo and were asked to increase the Cabo back to 40 milligrams daily. Primary endpoint is objective response rate. In terms of who is enrolled in the trial, what we would expect to see overall, a majority of these patients were white. In terms of histology, over half were papillary. We had some chromophobe, translocation, as well as unclassified. The IMDC risk groups were mostly intermediate risk. So as we look just at the beginning, treatment exposure, I think this is where we start seeing some differences from what we saw with 40. 9 patients were able to get at least 2 cycles, but 50% actually went on to get 4 cycles of Nivo Ipi, which is much higher than we saw with a 40 milligram dosing. And interestingly, 13 patients, or 65%, went on to increase their Cabo dose back to 40 milligrams at the recommended time frame. So that's great. What do we see in terms of efficacy? Well, we saw a 25% objective response rate. We saw responses across histologies, and we also saw responses across risk groups. And as you look at the waterfall plot here, we see that there are a significant number of patients that are still on therapy and results are ongoing. That being said, what about toxicity? Because that was the problem with the 40 milligram dosing, and I think that's where we see a marked difference with only 25% of patients needing high-dose steroids compared to 50% with the 40 milligram dosing. And in terms of grade 3 adverse events that occurred in at least one patient, we don't see anything super unusual. When we had the 40 milligram dosing, we actually had 2 incidents of myocarditis. So clearly a much better tolerated regimen. So what are the take-home points? Well, I think that 20 milligrams of Cabo combined with Nivo Ipi offered some encouraging responses in these patients. This is not going to move forward. I think that we have a lot of options in this space, but I think this trial provides a framework as we think about triplet therapy for smart, rational trial designs. A plus B plus C may not be the answer. Maybe half of A plus B plus C is the way we're really going to get to the optimal treatment so we can get the best outcomes for our patients.